Many people may know and understand that you can continue to be active and continue to exercise while undergoing prolotherapy treatments, but may not know what that means. And the truth is, it means something very different for everybody. You know, every patient that comes in may have some degree of knee instability, mild, moderate to severe, and have, you know, their own set of goals. Some people want to get back to running or tennis. Some people want to simply be able to walk in their house and not have pain and trust their knee. So, you know, exercising and moving while undergoing prolotherapy is very different for each person, as you could imagine. This chart actually explains it very well. So let's say somebody comes into the office and they have a severe instability, meaning that we've looked at their knee under ultrasound, we've done stress maneuvers to look at laxity of, you know, let's say their MCL or LCL, medial or lateral collateral ligaments, and let's say we see a severe instability. Well, that patient, you know, may require a lot of bracing on their knee. You know, if their knee is very unstable, those ligaments are very loose, maybe that's the person that feels like their knee is going to give out on them and they're actually walking less and less because they're so afraid of falling. You know, we may brace that person very consistently to, one, better allow, you know, prolotherapy to heal and stabilize the joint and give the patient maybe even a little bit more confidence to move more, you know, which we know is good. Either as the patient comes in and their instability isn't as severe, or as the severe instability, you know, becomes now just more moderate and more mild towards resolution, that's when activity level changes. Quite simply, we're not going to advise somebody with a severe knee instability to play tennis, right? That seems a little backwards. But as the knee gets more stable, then we might say, okay, let's kind of wean off the brace a little bit. Let's not brace it if you're just walking around your house or maybe walking around the grocery store. Still brace it if you're exercising. Let's start getting your muscles to start working more. You know, those are going to provide stability as well. That's, you know, your long-term secondary stabilizer to your ligaments. Let's get some exercise in building your muscles. Maybe try some, you know, lower impact things where we'll start in the pool, swimming, you know, walking in the water, using that to our advantage, maybe some cycling, especially specific to the knee, cycling, you know, typically non-weight bearing if you're staying in the saddle, good rotation, then build up elliptical. And then if somebody wants to run, we would say, let's jog. Let's do some walk jog intervals, kind of build back that endurance in your body before we start doing more jogging or even running or sprinting. Last thing, and you need a good amount of stability in your knee to be able to do these things, would be activities like tennis, pickleball, soccer, you know, activities where you're going to be doing quick sprints, you're doing a lot of lateral cutting motions. Maybe there's, you know, sports like soccer where you're on uneven ground. You need a lot of stability in your knee to be able to do those activities, so that oftentimes is kind of the last thing that we get patients back to, assuming we've kind of flown through all these steps well. Oftentimes when patients with knee pain or knee problems come to the office, I ask them, I say, hey, do you know what causes osteoarthritis? And I get a lot of great answers, actually. You know, people, you know, they talk about inflammation, or they talk about fluid, or they talk, say, old age, or, you know, oh, I had a trauma when I was 21, or I had a knee surgery. And not that those answers are necessarily completely wrong, but it's really not the answer that I'm looking for. So joint osteoarthritis, whether it's your knee, ankle, or whatnot, starts with soft tissue injuries. Now, could that be from an injury, you know, a big trauma or whatnot? Sure, but the soft tissue injury that continues over time and doesn't heal itself, doesn't get better, that's what leads you down the cascade towards osteoarthritis. So there's a lot of words on this slide, but if we just kind of look over here on this picture, top left, normal, healthy knee, tight ligaments, super strong, looks great. Well, let's say you sprain your knee, you know, you twist it wrong, you're playing a sport, you trip over a curb, what have you, and then you sprain, let's say your, you know, MCL or one of the collateral ligaments in your knee, for an example. What happens is if that doesn't get better or even gets worse, then you start to actually go down the cascade towards joint instability. And that means that the ligament is just simply not strong enough to hold the joint in a stable position. So what happens is you get these extra kind of micro movements. It's not like all of a sudden your knee's going to start dislocating right away, but you get these extra micro movements that over time will wear down your meniscus and wear down your cartilage. So if you don't, if these injuries are severe enough that they're causing joint instability and not getting better, that's what really kind of leads you down the cascade towards advanced knee arthritis and maybe, down the avenue of a joint replacement surgery. This can cause people to advance more down that avenue if there already has been a joint surgery. We know that arthroscopic knee surgery increases chances of arthritis. If you remove part of your meniscus, it's going to increase your chances of developing osteoarthritis later in life. So you can kind of speed through this cascade with things like that. Down through here, if we say, there's ligament injuries, we know the joint is unstable, especially with motion ultrasound, and we can treat those. We can get those ligaments strong with prolotherapy. We can restore stability in the patient's knee and hopefully prevent, that kind of long-term journey towards advanced osteoarthritis and knee replacement. Common questions that we get about people that come in with knee pain. We have them listed here. What if my MRI didn't show anything, but I have pain and my knee feels like it's always going to give out? Super common. You come in, your knee, maybe it's a perfectly normal knee MRI, or maybe it says, a little bit of, mild degenerative changes, but nothing that explains what's going on. That's pretty common too. Well, the thing about MRIs is, one, you're not moving when you get an MRI. So do they give us a great picture of what your meniscus looks like and, maybe even your cartilage? Sure, but you're not moving. So how do we know what is going to cause your knee to give out if we're not really testing it when it's in motion, right? So in cases like that, we would definitely want to do a motion ultrasound and see, do you have ligament instability? Is that actually what's going on in your knee that's causing it to feel like it's going to give out because it's not stable? Or maybe, your knee MRI looks pretty normal, and on motion ultrasound, your knee is pretty solid. Well, then we got to figure out what else is going on. Is there a muscle imbalance? Do you need physical therapy? Do we, other strengthening type things? Do we need to look at your hip and your ankle? What else are we missing aside from just what the MRI shows? The other thing with that is we know that our ligaments and even our tendons have a lot of nerve endings. So if you have a ligament injury where it's not torn, it's just kind of stretched out like a stretched out rubber band, your MRI might not pick up on that. Maybe not pick up on it if it's loose. And then too, if that ligament is injured, because it has so many nerve endings, it's going to hurt like heck whenever you bear weight on it and use it. Another common question that we have: I've been told I'm too young for a knee replacement, but I have terrible pain and steroid shots only last a short time. Would prolotherapy help until I'm old enough for a replacement? Well, a couple things to point out here. Steroid shots can do a great job of masking pain, right? You get a steroid shot, you might feel great for 3 months, 6 months, 2 months, what have you. Steroids are going to do a couple things. One is they're actually going to degrade your cartilage faster, and they're going to block the pain. So you can go play tennis, or you can go play pickleball, or whatever sport you want, and you're just not getting like the information from your knee that it hurts. Stop doing that. That signal is completely blocked. So you're actually causing more damage to your joint, but you're just not aware of it because you're not getting that normal pain signal. Typically, patients, they'll say their first steroid shot was great. It worked for however long. Things were fabulous. Started to wear off, so I got a second one. Well, that one didn't really work as long. Maybe the first one lasted 6 months. This one lasted 2. All right, so then eventually I go for my third, and it did nothing. It was like 2 days. What happened? Well, your condition has quite simply gotten that much worse. It's degraded a lot faster. So when people have this history, very, very common that they're not recommending those anymore. They're saying replacement. Now I need to figure out another alternative. If that patient comes in and they have pretty good to decent range of motion, we look on their ultrasound and they've got joint instability, they've got ligaments that are too lax, bones are moving more than they should. Typically, and this is a very generic statement, but typically those are patients that do well with prolotherapy, and we can oftentimes delay a replacement, but really our goal would be to avoid it if possible, depending on how bad the patient is when they first arrive. So yes, the answer is yes, we can, in a lot of cases, work to delay a replacement or even prevent it as long as the person takes care of their knee and takes care of themselves. Another common question: why don't you just use PRP or stem cells on their own? Why do you always do dextrose prolotherapy in conjunction with those? And the short answer is because we get better long-term results. Most people with knee instability or knee pain will have some benefit if they just did one PRP shot in their knee or one shot of stem cells in their knee. But we see all of those patients here is they say, yeah, it was great for 4 months and then everything came right back. Or, it was good, but I still didn't get back to the activity that I wanted to do, even though I had less pain walking around my house. It's not uncommon for people that have knee pain, especially as we get older, to actually have knee pain in both knees, whether one has always been the worst one and the other one started to act up. Can you treat both knees at the same visit? You certainly can, and that can vary by patients, in preference and so forth, but we absolutely can safely treat both knees at the same time. How many shots is that? Well, it's double the amount of doing one knee. So it could be 30 injections, let's say, give or take on one knee. You do that twice, 60 shots in one day. Sounds like a lot. It is a lot, but that's the best way to comprehensively treat these joints for long-term results. Everybody always wants to be better yesterday, right? That's kind of the society that we live in. But we at this office do a really good job of thinking long-term. It's not just about, hey, can I get you feeling better tomorrow? That's not really our goal. Yes, that's great and that would be lovely, but we want this to be a need that you can use and play sports with and live your life with for a really, really long time. Not just trying to get you through the summer and then, start something else to treat your knee pain later. Like, we want this to work long term. That's why we do so many injections, because we're very comprehensive. This is actually one of my favorite questions. How long does it take to notice improvement from prolotherapy? So someone comes in, it's their first visit. We do, our initial evaluation, ultrasound exams, review imaging, come up with a treatment plan. This person's a great candidate. They'll say, well, when am I going to feel better? I say patients typically fall into one of three categories. So some people after their first treatment will start to feel better right away, which is, they're like, oh my gosh, this is great. And then maybe, over the month leading up until their next treatment session, they might say, hey, I felt really good. And then I kind of started to feel maybe more like I normally do leading into the next treatment. Still better than my baseline, but, just maybe kind of this arc of improvement. Totally normal. Some patients will say, I didn't really feel anything right after the treatment, but as I got closer to my next appointment date, things started to feel better. Great. Totally normal. Other patients will say, it's just been kind of a weird month. I feel like I had some good days and then bad days and some good days and then bad days. And, maybe I'm not so much changed from baseline or maybe a little bit better, but it's been kind of a roller coaster month. Great. Totally normal. Very hard to predict who is going to be in each category, but all three of those are pretty common general kind of waves that patients follow between their first treatment and their second. And then as the treatments build upon the previous one, patients will start to feel, increases in feeling better, have better good days, start to do more, need less pain medication, those kind of things as the treatments go on, which is really what should happen. We should see over time that patients feel better, and we should see, changes on their ultrasound, changes on their physical exam that correlate with that. Hi, I'm Danielle Matias at Caring Medical Florida, here with our patient Jean, who actually showed up this morning for her 5th treatment to her right knee, possible 4th to her left, and we're actually not doing anything today, right, because she's doing so great and her knees are stable. So here we are. Tell me, before you ever came here, tell me how things were with your knees.
Pretty bad. Although that being said, I have had PRP treatments.
Yep.
But they'd last about 6 months, and I didn't know about your organization until my chiropractor said, well, maybe you need to try them, because they do it a little differently. And when I first met you, I was scared. I won't lie.
I remember.
I can remember the comment saying they're gonna give you many needles. I said, many needles? But in any event, you kind of went through the process with me, telling me how the treatments are going to go. When I heard long term, I was like, ooh, really? Because they only did it once. And the first treatment was tough, then it got better, but now, I was just telling you, it's been 20 years since I've been able to squat, and I can squat.
20 years?
20 years. I gave up tennis probably 30 years ago because I couldn't do the jarring, and I've added 10 yards to my golf swing since this treatment.
That's what it's all about, right?
For me, it's all about being active.
Yeah.
And I would climb stairs one leg at a time. and I'm forcing myself, because it is a learning process, which you've told me, to trust my knees again, which I couldn't do.
And to go back when you were saying you had PRP before, previously, it was just a one shot into the knee.
They took my blood,
Yep.
spin it, and then inject it, and I'd walk out.
Yeah.
And it worked. Don't get me wrong, it worked.
Sure.
But it was not. It wasn't stabilizing. It was taking care of the pain. So I wasn't feeling pain, but my knee wasn't getting stabilized. Is how I would put it.
Yeah, I think that's a fair description of that.
And now my knees are very stabilized.
And now today, the biggest reason that we're not doing anything today is not only is your pain reduced, but your knees are actually completely stable on ultrasound. So
Yes.
everything has done exactly what it should do, and getting you back to golfing and doing all the activities you want to do to live a healthy lifestyle.
Correct.
And with what you were saying, you talked about trust today. If you have had pain for decades and you have really kind of babied it, or just kind of modified your activity, it's going to take you some time to trust your body again. You're stable, you have the clearance to do things, you just got to get that muscle memory.
It's we were just talking about golf. It's muscle memory to trust the knee, and it's really the right knee was worse. The left knee I trusted, but the right knee I didn't. And now I'm finding the right knee is as strong, if not stronger, because
That's amazing.
It's just working. So I'm totally excited. It's been a scary venture, but it's been absolutely worth it, 100%. As I told you, everybody that I talk to, I tell them, before you get surgery, look into this for everything.
Well, I'm thrilled. Thank you for that. And I'm thrilled that you are doing so well.
I am excited.
Yeah. And this is like your graduation.
My graduation.
From Prolotherapy today. So
Yes.
Congrats, graduate.
Hopefully I don't need any other, but if I do, I'll be calling you.
We'll take
For
care
sure.
of you. Hi, I'm Danielle Matias here at Caring Medical with a longtime patient of ours, Allison, who's actually here today for a shoulder pain, but you've been getting Prolotherapy since like 2006.
Yes, I have.
Yeah, so this is actually, I didn't treat you back in 2006, Dr. Hauser did.
Yes.
But it was knees, neck.
Yes.
Okay.
Yeah.
And so
Both.
after treatment, this is 2006, a long time ago, what have you been up to since then?
I've run a number of marathons. I think the last one was 2016. I was
Wow.
going to keep going, but I love golf and tennis so much. So I said, oh, something's got to give, but I still get out on the path and do anywhere from 5 to 10 miles a day.
Wow. Did you need maintenance after that? Or you just had your treatment in 2006? Okay.
No, it's one of the things that was the best decision of my life.
Wow.
And if I could do it over again sooner, I would have.
Okay. What did you, if you remember, out of curiosity, prior to seeing Caring Medical and Dr. Hauser specifically at that time, what were you doing to help your knee and neck pain?
Actually, in 2006, I was in a head-on collision that caused a great deal of, say, trauma to the body, right?
Yeah, absolutely.
And I was getting, getting opinions, have surgery and you could repair. I was like, no, because I know I still want to run marathons, play golf,
Totally.
tennis, and be active. And I got to know that regenerative medicine, prolotherapy was specialized by Dr. Hauser. I'm in, count me in. And for maintenance, I still take glucosamine, but I'm out every day. I do my exercise. I still do weight training. I used to be a bodybuilder too, so that probably added to the stress in my
Wow.
body. So.
Okay. So after your accident, you were given the option of surgery. Yeah, and thank God you didn't.
No, I did therapy, and then they were like, "Oh, we're going and clean out your knee." I went, "No." I'm really conservative when it comes
Yeah.
to cutting on my body, and I said, "No, I want to try something different," because I knew the future is regenerative medicine, and I'm the walking billboard.
You really are. And your neck is holding up well? Neck
Fantastic,
pain?
everything. I'm great.
And so what did you tell me your goal was now with your shoulder? Your 100-mile-per-hour tennis serve?
Yeah, I played. Yeah, I do. Honestly, I used to, and some of my friends would say, "Oh yeah, we knocked the racket out of the hand." But I want to play golf like I do. I want to play tennis, and I want to pick up pickleball, as well, and still run and be
Okay.
active and well into my 60s, 70s, because I'm still in my 60s, and I want to go do this till I'm in 90. So
Good for you. You gotta be careful with pickleball because it's apparently very, very addictive.
I hear.
Yeah.
Yeah, but I love serving. 100 miles per hour.
100 miles per hour.
Because of prolotherapy and regenerative medicine and Caring Medical. If anyone, I tell anyone is ever hesitant, is this good for me? Don't hesitate. You'll only do yourself a disservice because you'll thank me for later saying, I listened to that guy and look what happened. it changes your life. It changes mine, Danielle. And thank you
Oh
for
my
what
gosh.
you do. Thank you.
Anytime. Thank you for, you take care of yourself. You do a lot of the work too, You put
Because of
in
you
all the
guys.
time.
It's because of you guys.
Well, thank you. You're very kind.